nodule. So even in low power, we can, because this lecture, this unknown is about this bubbly clear cytoplasm differential. So when you see the epidermis kind of pushing by this kind of mass, you need to think of two things. Is it primary from the skin or coming from somewhere? Especially when you see this nodule do not infiltrate any normal structure. They just pushing out everywhere, and then do not have anything infiltrated into the epidermis. So if you think this is a benign, it could be a benign thing, but you should always bear in your mind from this not primary thing, it could be metastasis. So and then right now you have two differential. One is benign, totally benign, and then one is metastasis. So you need to go down to see what's going on with this one. So even in this power, we can see this bubbly clear cytoplasm, but between this cell, we have this kind of, from this power, maybe just fibrous tissue separate this nest of cells. And then, but when you go down more, you can see there is some hole and some red blood cell inside. So this is rich vasculature in this neoplasm. And then with this clear cytoplasm. And then the cell not really polymorphic, but they just have this monotonous looking. So when you see this clear cytoplasm with this delicate web, we have so really rich vasculature, and then in the skin do not infiltrate anything. So that is the metastasis. And then combine all of these features, this is a metastatic clear cell renal cell carcinoma. So of course, for the H&E, when we see this, even we know the history from the patient, we still need to do the staining. So when you think about it, just put a PEX8, and then you can just tell you it's from the kidney, and then you can make the diagnosis of this one. Okay, and for another case, anyone want to volunteer to pick up whatever case they want?
I can do one.
Yeah, just pick up whatever number you want.
Do you want to just keep your screen?
I think just keep my screen.
Okay. I'll do one. Okay.
Which one is your favorite? Number 3. Oh, that's a good one. Yes.
Purple is what we see. That's very busy. I kind of see that there is a sort of like many surface crease, and then you can see them going to the bubbly stony cells that we've been talking about. So we see a lot of histiocytes in there. And the other thing that's going on is some really good, like you can kind of notice that there's a little bit of like a so it's like this icy, kind of like rosy color, and then there's like a little bit of a darker color inside as well. So it's usually that sort of two-tone cytoplasm gives this very cool diagnosis. I think we can see, I don't know if there's some like lines I think there are anyway, like when you use Xanthoma, but we also see some giant cells as well. So this would give us the differential for reticulohistiocytic melanoma, and this can be present as one like nevus, or they can be minor, and if the multiple nodules are present from a patient, then you'll want to think about multicentric reticulohistiocytosis, and so that would give us sort of like a different clinical finding. Debris in its surface. And you can think about just sort of Xanthoma as well, but the plasm helps out with that.
Yes, that is the reticular histiocytoma. As Gasa mentioned, if just single lesion, don't worry about it. If multiple, you need to think about kind of any systemic disease or anything. And then we have a really good differential when we have all of the three things. I would like to differentiate them, so we can just continue. Anyone want to volunteer to take one? We already have second case and that's third case. Sure. Number number 10. That's also a good one. This is also the one. Want to do a summary? Yes. Go ahead, John. Okay.
Looking at the cells on my tower, I was seeing funny histiocytes.
That's a good thought.
Very specific giant cells.
Yeah.
Two giant cells.
Yeah. 2-ton John cell. Yeah. Yes. That's absolutely correct. So yes, this is JXG. Especially, I give you the history. 15 years old female with neck nodule. So so then I can talk one more case by myself, and then we can do a summary of that. The next one I would like to talk is this number 11. 70 years old male with neck nodule. So from low power, we have these kind of exophytic growth nodule with this almost color red with the epidermis hugging this nodule in the dermis. And then low power, we can see, we always talk about low power from DOMPAT, we can see kind of bluish in the periphery and kind of pink inside. So blue and pink, you think about this bluish area should be some inflammatory cell, especially lymphocytes. And then this pink area should be histiocyte. And then we just zoom in to see, yes, we have turned off inflammatory cell around. And then also we have some cell histiocyte with this bubbly cytoplasm. And for this one, we have really characteristic cells like this histiocyte. They just engulf some maybe red blood cell and other inflammatory cell. So if you think about this diagnosis, you will always pay attention to this. So this phenomenon is amperipoiesis, not specific for Rosai-Dorfman, but if you think of Rosai-Dorfman, you will try really hard to convince yourself that it's amperipoiesis. And then the cytology feature for this histiocyte, you can see this prominent nucleoli, and then the nuclear membrane just kind of, you use a pencil to just draw this nucleus membrane. So this is the cytology feature for the histiocyte in Rosai-Dorfman. So you will find tons of lymphocytes and then plasma cell. So when you see plasma cell in this kind of lesion, you will just think of what's going on with this plasma cell. and then you will look for other feature for the final diagnosis of Rosai-Dorfman. And then we also can see this foamy histiocytes. So the reason I would like to talk these three cases together, because low power, you always have these three as a differential, even the age is not matched, just like the xanthogranuloma, JXG, juvenile xanthogranuloma, but you can see this kind of xanthogranuloma in any different age. So low power, they look really the same, like a nodule with some inflammatory cell and then pink sheets of histiocytes. Let's go back to this number 10, JXG, juvenile xanthogranuloma. So even low power, you also can see some inflammatory cell in the periphery and then pink sheets of histiocyte inside. And then for this one, John already mentioned this is tons of two-tone joint cells. And then these two-tone joint cells have this foamy looking cytoplasm. Then if you have tons of these two-tone joint cells, it's really easy to make diagnosis of juvenile xanthogranuloma. But some cases, especially in the really premature cases of xanthogranuloma, you may just have several of these two-tone giant cell, and then for the rest of the cell, just this foamy histiocyte, and then mixed of different kinds of chronic inflammation. So in that case, you still can make the diagnosis because of tons of these foamy histiocyte and chronic inflammation. And then we just go back to case 3. So for the low power, they still look the same. Some dark area in the periphery and then some pink area inside. And then as Gazar mentioned, for this one, we can see really rare multinuclear joint cell. And then even sometimes they will look like of two-tone joint cell, but you just have really rare. But that is not the most important thing when I tell the difference between these three. Reticulohistiocytoma is this two-color cytoplasm of this histiocyte. So this one we call this two-tone giant cell, just two different color. Then another important feature is that you won't see tons of foamy histiocyte. Some may be foamy, but not tons of them. So and then let's share my PowerPoint. Okay, could you see my PowerPoint? Yeah, so the summary of these three, we always put them in the differential in low power. So I just highlight for this reticulohistiocytoma, we have glassy highlight appearing eosinophilic cytoplasm. We call this two-tone giant cell, but we see less giant cell. And no, that's a two-tone histiocyte. And then we have less giant cell and less lipid-filling histiocyte. And then for the JXG, we have more foamy histiocyte and then more giant cells. And then for the Rosai-Dorfman, we can see a little bit lipid-filled histiocyte, but we have plasma cell and we also have empyropoiesis. So from Dr. Gardner's YouTube video, we can see this is the two-tone giant cell. We have two-color cytoplasm. And then we have a little bit foamy histiocyte, but not tons of them. And then this is the JXG. This is two-tone giant cell, and then tons of this foamy histiocyte. So sometimes if you do not have a lot of this giant cell, but you can see a lot of foamy histiocyte, you still make the diagnosis of juvenile xanthogranuloma. And then for Rosai-Dorfman, as we know, we have this blue lymphocytes and then this pink histiocyte, and then we can see this empyropoiesis. So hopefully next time you can make the diagnosis of these three and put a good differential. Okay, let's continue. Anyone who want to volunteer? Any other cases? Sure. Yes, we have done the first one.
like cystic areas in this power. So I would like to have power and say what kind of software you have in power. So here we can understand like the with the cells when they have very monotopic around nucleus. And then there are few cells when they have like this kind of like eosinophilic cytoplasm, but mostly we have like a clear cells. Also in their picture, like they're making more like a cystic structure. So in this lesion, we can see primarily like sometimes they have tumor, sometimes they have cystic, or sometimes they can also have mixed and cystic tumors as well. And so the other thing I wanted to mention, like when we were the low power, like if we see like it's mostly on the dermis, I see like in the epidermis environment as well. And even it's not even that clear in this one. And so we were talking about the cells appearance, and these cells are like very pyrroid looking, or even like a cuboidal looking cells. And I wanna see the duct here. Can you point out the duct? Like we usually have in this one the eosinophilic, they call it eosinophilic particles. So, and yeah, so we talk about the clear cell part, the clear cell feature, eosinophilic, and eosinophilic cuticles duct present, and these are mostly in the dermis, design well the epidermis, so this would be hydrodenoma and nodular cystic hydrodenoma.
Yeah, that's perfect explanation. So again, this low power, as Cyrus mentioned, usually this hydrodenoma do not connect to the epidermis. So even sometimes we have the epidermis, but they usually common, they do not connect together. And then we have this collagenous stroma, and then also nodular and cystic. So from low power, you already put hydrodenoma into your differential. The, the characteristic of this clear cell variant is that we can see tons of this clear cytoplasm, but we can have this kind of eosinophilic cells, so we can tell as this is hydroadenoma because we still have this conventional area. And then again, sometimes you may also think, oh, is it this myxoid or mucin stroma for a mixed tumor? Yes, it could be, but usually mixed tumor we have more conjoined myxoid stroma like this, and then not this cystic and nodular mixed together. Then more characteristic feature, as Cyrus mentioned, because this is sweat gland apocline differentiation. So we can always find this sweat secretion forming this cuticle or this sweat duct differentiation. So that's really important to make the diagnosis because this hydrodenoma still fall into the sweat gland tumor category.
One quick thing I would just mention, like, because the think about it could be NETs, but it's like an epidermal cell carcinoma because it's like doesn't have any link to the epidermis. So if we just see the dermis, also the clear cells, so it kind of like one of the differential could be renal cell clear cell carcinoma. But important thing to look at, like, those are like, of course, no typically monotonous looking, and the main feature is this is like a sweat duct, so you will see like a cuticle line duct. But in the renal cell carcinoma, you won't see these ducts. You mostly see like, you might see like a fibrovascular core, or you see like some like red blood cells, but my main point is just to cuticle line duct when you think of lesion only in the dermis and more like a clear cell looking, just to have differentiate from renal cell carcinoma.
Yeah, for the clear cell renal cell carcinoma, you want to see delicate uh, vessel, and then you won't see this sweat duct differentiation like this second case. Like the whole thing kind of look like the same. You won't see this structure. Okay, we can go for the next case. We already done almost half of the cases. Yeah, sure. That's a good one. Yeah.
There's no pleomorphism at all, but lots of phytoplasm. I was trying to find the balloons and melanoma by clearing variant. I think I'm gonna go with this one because of the like junction. I think I saw the similar cells on the like maybe those were melanocytes that is differentiating to Ballon cells, but I might be wrong. I'm not sure.
Yeah. I want to mention when you see this bloom cell changes of a nevus, you should suspicious for melanoma. But as Alok mentioned, we can see this conventional melanocyte, and then we have this bubbly differentiation of the melanocyte. So we know this is a kind of nevus or maybe melanoma with these bloom cell changes. But when we look at the epidermis, it seems this cell, maybe this is melanocytes, but they do not show this melanoma in situ feature. They do not form this confluent growth. And then we do not see pegytoid spread. And then low power, we can see looks kind of exophytic growth. And then if we put a line in the middle, kind of symmetric from left and right. And because we do not see the in situ component, so this one still favor benign nevus with bloom cell changes. And another clue is that we can see these cells do not show any polymorphism, as Alok mentioned, look benign looking, and then no mitosis we can find. And then we can see a little bit maturation of the melanocytes. Maturation, that means in the superficial dermis, we have some big cell and then forming this nest. And then when the melanocyte go down, they will kind of sparse like this. They do not forming this big nest. They just try to forming more singly, maybe small nest of cell. So this is one thing of the maturation. But of course, we need a lot of marker and then good clinical history to tell whether this is a melanoma or nevus. We can put a praying. I think this one praying should be negative, and the other melanocyte marker should be positive. But still, this one is really tricky and not that straightforward to tell the malignant or not. But the good thing should be bear in mind is that if you do not see the melanoma in situ, that means this one either a metastasis. It could not be a primary. So as a contrast, we have the true melanoma. That's the case 12. So for this one, as a in contrast, if we put a line in the middle, this one is not symmetric because we have more like bloom cell changes here, and then we have more conventional here. And then more importantly, when we go down, we can see this next, and then forming this confluent growth, and then also some pegytoid spread. So, and then this is in situ of the melanoma. And then there is more convincing finding of this part should be coming from this conventional melanoma in situ and then going down. And then for maturation, you can see this one, they still forming nest, even they go really down, really deep down, they still forming this nest. They do not go sparse melanocytes, so they lose the maturation. So we combine all of these feature asymmetric, and then melanoma in situ not maturing when the melanocyte going down. So this is a balloon cell melanoma. And I think everyone already take some slide. So anyone still want to volunteer, or I can just go through, finish the rest of the slide.
Yeah, I can try one more.
Sure. 13. Okay. Yeah. Yeah. You're absolutely correct. So whenever we see this bubble cytoplasm, other than all the clear cell cytoplasm diagnosis we already talked about, they would be species differentiation, especially if we can see some kind of maybe a hair follicle thing happening here. So this is species adenoma. So whenever you see this species differentiation, you should always put some differential because species adenoma is one of them. And then the other one is species hyperplasia. And then some other diagnosis just like uh, for Fordyce gland, and then some other differential is spacioma, even spacious carcinoma. How could you tell the difference between all of these? First, for the Fordyce gland, that means in the lip. You should know the anatomic location. That's the lip. And then usually in the lip, you won't see tons of spacious gland. If you see them, that means these spacious gland are just in a not a normal location for them. So we will call that Fordyce gland. Then the other one is spacious hyperplasia. As a contrast, this is spacious adenoma. If you want to call this spacious hyperplasia, you won't see this basaloid cell in the periphery. You may see maybe a little bit, just one layer of this basaloid cell, just like this in the periphery. You could not see the perforation, like they have multi-layer. So when they have basaloid cell forming this hyperplasia multi-layer, you at least you need to call this spacious adenoma. And then compare spacious adenoma and spacinoma. Just depends on this eyeball of overall this architecture. If you have more than 50% of this tumor have this basaloid cell, you will call this spacioma. And then if like this case, you have more bubbly spacious differentiation, more than 50% of this cell, you will call this spacious adenoma. And then you need to bear in mind that in this spacious tumor category, you can always find this mitosis, but you won't see a typical mitosis. If you want to call this a spacious carcinoma, you need to see a typical mitosis, tons of mitosis, and really significant polymorphism. And then more importantly, you need to see this kind of tumor just infiltrated growth of the structure surrounding them. And then for this one, because we can see this really well demarcated and then more spacious differentiation cell than this basaloid cell, so we can make diagnosis of spacious adenoma. And I think we have a score system to tell us, I think it is an app, I think from the ASTP or maybe whatever society, they have an app as a score system. You can pick all the clinical feature and the diagnosis there. They can tell you a score, whether you need to do microsatellite marker, like the one we do in the Lynch syndrome, because this kind of spacious adenoma, if you have multiple, you may put a suspicious for Murray syndrome, one of the variant of the Lynch syndrome about this microsatellite instability. Okay, and anyone still want to try?
Did we do number 9?
Number 9. Yeah, sure.
Okay. Okay, so if we select these three pieces, I just remember that I was including with them. Lesions, so I would just pick the last one. Yeah, this one. So, this one is like you, and I would say usually like a superficial damage, like a bone damage, and it kind of what I was just trickling down deeper dermis as well, inside the prescription, but the lesion mostly in the dermis. So it's just high power, honestly. And this power and also the thing to notice is more like a eosinophilic thing. Yeah.
First, could you tell us where is the location?
Oh yes.
Yes. So what do you write?
And they have lipid inside them, so we call them this lipid-laden foamy histiocytes. And the important feature is they like to make it like cluster around blood vessels. There doesn't have to be, but like there's also one of the clue, like you usually see like these foamy histiocytes are forming cluster around blood vessels. Again, mostly in the superficial dermis, epidermis is pretty clean. So this would be another important feature, like that's the lesion is on the eyelid. So if you think about like clinically, like so this is even like in this one, we don't know the history, we don't know the location, but just looking at this, like you can see it's with these follicles and like a very thin epidermis, and this layer follicle, we just think about like, okay, this could be eyelid, and then again the foamy histiocytes, so that this would be Xanthelasma.
Yeah, this is Xanthelasma because this is in the eyelid. And then we have another case is number 7. That is just a Xanthoma. I think these two just identical, but just the location. So we still see this foamy histiocyte. We call this Xanthoma cells. And then just forming this sheet, they do not form any architecture. But just like Xanthoma in any other location, like in the gastric, we also can see this kind of lesion. So go back to this one. Yeah, so even I didn't tell you the location, you can figure it out because really thin skin. Usually in the skin, you will have more dermis and then you will have this fat. But this one, the dermis is just really thin. And then we can see this white space because in the eyelid, there is really loose uh, skin. So you can see this space, kind of edema, something like this. But you can just imagine in your eyelid, it should be really loose skin. And then another feature is that we have tons of these small follicle. They do not go really down deep. So there's kind of villous hair-like follicle. There is another clue. We are in the eyelid. And then sometimes we can also see uh, kind of smooth up some skeleton muscle there, but this one is not that dramatic. So when we tell the location and then combine with this xanthoma cell forming this sheet, so this is Xanthelasma. Another volunteer, we just have 1, 2, 3 left. If no, I can just continue one by one and finish them. So number 4, this is a really tough case. So from the answer choice, I think for the rest, you can think about this one. This is a PEComa. So, I mean, this one is really similar to the metastatic clear cell renal cell carcinoma from my eye, but a little bit different. They all of these two have this clear cytoplasm, but you can see these tons of this collagen. And then in the clear cell renal cell carcinoma, you will see this is not collagen. They will have delicate blood vessel, but this one just have more of this uh, collagen inside this tumor. So, and then of course we can use immunohistochemistry staining, because if you do not find this collagen bundle, and then just give you this area really identical to the clear cell renal cell carcinoma. Even some can show this prominent nuclear line, just like nuclear grade 2 or 3 renal cell carcinoma. So of course, we can do the marker like PEX8. Of course, in the renal cell carcinoma, it should be positive, and then for this one should be negative. Then the characteristic feature for this one, we can flow some melanosity marker like melanin, and then they can also have differentiation of the small of the skeleton, whatever muscle you want. So you can put small muscle actin for this one. So if these two are positive, you will really highly suspicious this is PEComa. And I think this one for SOX10 and S100 should be negative. So if you are thinking about anything melanocytic, you can also do these two marker, and then to prove you they are not uh, melanoma. And then in the internal organ, PEComa, also we will call this AML, right? Angiomyolipoma. But for the skin, we just do not see the feature of any AML. And then they are not usually related to TFE3, because in some internal organ AML, they are related to TFE3, but this one is usually not. And then the prognosis is really good from this one and really rare. So I think in a superficial skin, when you see this clear cytoplasm, looks like renal cell carcinoma. I think it's just renal cell carcinoma, not cutaneous PEComa. And then number 6, I give you a diagnosis. This one is bacterial infection. So low power, we can see kind of really busy in the dermis, maybe a little bit acanthosis, hyperplasia of the epidermis. And then we can see this really pale, like edemas, or maybe the cytoplasm is really clean, like the case I show you. But when you zoom in, you can see inside this hole, you can see this organism here, 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 here. When you zoom in, you just see them everywhere, but they do not have any pigment inside. So we already know this is bacterial infection. What kind of infection do you think of?
Cryptococcus.
Yeah, Cryptococcus. This case is really nice. We can see tons of them. So Cryptococcus, usually you will have capsule, and then we can use Indian ink. And then we can also use using carmine to highlight their capsule. But there is another crypto, they don't have this capsule. Anyone know what staining we can highlight them? Other than GMS, the silver staining can highlight this thing. But if this is a non-capsule related crypto, what kind of staining you can think of? The one we use to highlight the melanin, that is Fontana Massage. Yeah. So this crypto, usually in the immunosuppression patient. So again, let's go to the last case. This one also a tough case. Of course, I already give you the diagnosis. This one is clear cell sarcoma. So in the low power, we can see this nodule in a deep soft tissue mass. And then we can see this nest of cell, and then they separate by this collagen bundle. And then some cells show kind of spindle, some cells just show this round. It depends on how you cut this cell. If you cut this longitudinally, you will see this spindle cell. If you just cut a cross section of this cell, you will see this round nucleus. And then the cytoplasm is really clear. So that's the reason we call this clear cell sarcoma. And then the immunostaining for this one is really tough because you can just see really identical immunostaining for melanoma. But if you do not have a history, and then especially I give you the history of this one, it's a young, this is number 8. This is 35-year-old male deep fit nodule. So just everything if you don't have melanoma history. So it is not unlikely in this young age to have metastatic melanoma. So you need to think about of clear cell sarcoma for this one. And of course, the marker just identical to melanoma because the old name of this one is clear cells sarcoma of Swart. And then we have really characteristic fish for this one. Oh, and then I would like to mention because this one has translocation EWSR1 ATF1 or EWSR1 with the CRAB1. For whatever soft tissue tumor, when you have translocation, the cell looks monotonous. The cell just do not have this polymorphism. They look quite the same. So for this soft tissue one, you always need to put a fish to make the final diagnosis. I think pretty much it. Any question? If no, we can conclude session and then you can have 15 minutes back. Thank you, everyone.
Thanks, sir.
Thank you. Thank you.